Hi, good morning, and welcome to Grand Rounds. I was just reviewing with Sean the lineup for the remainder of the academic semester, and just to share with you. So the next week, we're going to invite one of our own, Frank Nelson's going to be with us to talk about fatty liver disease, and we've really been so happy to have Frank amongst us the last year or so, and look forward to that lecture. And then we'll have a couple of scholarly lectures from our trainees. We do a bit of a roundtable recognizing folks that have been presenting nationally and often have won awards. And then there's a senior lecture subsequent to that. And then we'll wrap up the season with my town hall for the spring. And also Matt Weissman's going to be with us for our final lecture of the academic semester. Matt's the chair at MSBI and has done a lot of great work in how we reach communities who are challenged to get excellent medical care. So we'll look forward to welcoming Matt to us. Anyone that's spent any time in internal medicine knows that one of the most common reasons why patients come to see us is because they suffer from headache, often disabling, certainly interrupting their lives in ways that are impactful for them. And further, anyone who's spent any time in internal medicine knows we're often challenged to clearly diagnose the cause of their headache and also effectively treat it. Just yesterday, I saw a patient at the Ryan Clinic with one of the trainees who suffered with headache for 15 years. Her current approach to treatment, because we've basically failed her, is she has her sister get medications for her from Canada, and that's what she uses to manage her headache, because anything we've tried really have not helped her. And that's just one example of what I know all of us have experienced in caring for patients. And in that context, we're so happy to have Netta Hindiyeh with us today, who is the Assistant Clinical Professor of Neurology and Neurological Sciences and part of the headache and facial pain team at Stanford University. Dr. Hindiyeh got her undergraduate degree from UCLA and then her medical degree from the University of Toledo, and then headed back to California for her training at UC Irvine, her internship and residency, and her fellowship at Stanford. And it's done really wonderful work in all aspects of both diagnosis of migraine, where we're still very much challenged, and she's the recipient of a 2013 clinical fellowship from the Academy of Neurology to help us better diagnose patients with migraine and really know how to systematically do that. And then has done important work as well on how to effectively treat migraine as well as cluster headache. Dr. Hindiyeh, it's really a pleasure to have you with us today, and thank you so much for sharing.
Good morning, everyone. Thank you all for being here. So I'm going to talk about diagnosis and management of headache, focusing mainly on the primary headache disorders. So what I want to start with is a case. Let's meet Sarah. She's a 49-year-old woman who comes into your clinic with a chief complaint of increasing headache frequency. So she reports headaches started for her around the age of 13. In her teenage years, they didn't happen that frequently, maybe about 9 times a year. Over the next several years, they started to increase. And by her early 40s, they were happening about once a month. They significantly increased after her bilateral oophorectomy at the age of 44 and were occurring 6 to 12 days out of the month. She had even more of an increase in 2018 to 12 to 21 days a month. And over the last several months, headaches were occurring 25 to 28 days out of the month. And what she noted was sometimes they would occur every single day. So she felt like she had 2 different types of headache. She had one that was more of a mild intensity, and she felt like this was happening more days than not, about 15 to 20 days out of the month. This one was more of a whole cephalic pain, more of a pressure-like tight sensation, and kind of with her all the time. But about 8 to 10 days a month, she had more of a severe headache. This was described as throbbing, usually right temporal, but could be in the orbital region as well, and could distribute and radiate bilaterally. These more severe ones lasted 1 or 2 days if untreated and were associated with photophobia, phonophobia, osmophobia, nausea, and vomiting. She reports having an aura about once a month described as rainbow slits in her binocular vision, and sometimes some tunnel vision. but she denies any autonomic features or any positional component to her headache. So a lot of things would exacerbate or trigger headaches for her, including stress, red wine, perfumes, and before her surgery, her menstrual cycle. And in terms of what she's taking now for her headaches, she'll take sumatriptan 100 milligrams. She does this about 5 to 10 times a month, and ibuprofen 15 to 20 days a month. She does get some mild benefit from these, but nothing significant. In the past, she's tried various amounts of acute treatments, but she's actually never tried a preventive medication for migraine or any type of headache. She feels pretty disabled by her headaches now. Recently quitting her job, trying to go back to school, but feeling overwhelmed and stressed because of headaches, unable to handle this, and while searching for a job and raising her daughter. In terms of her sleep hygiene, she wakes up pretty frequently throughout the night and has difficulty falling asleep and has been diagnosed with insomnia. In terms of her nutrition, she does skip quite a few of her meals, has about 1 to 2 cups of coffee a day, but doesn't smoke. And in terms of exercise, she will do some cardio about 4 to 5 times a week on the elliptical machine for about 30 minutes. And her past medical history was significant for the bilateral BSO that I mentioned. She also has a history of kidney stones and factor V Leiden. In terms of her family history, both her mother and sister had been diagnosed with migraine in the past. And in terms of social history, she's divorced, living with her daughter, and drinks about 1 glass of wine a month. Her physical exam is pretty normal. I just wanted to mention a few things. Her BMI is on the lower side, so she's considered underweight. And in terms of her head and neck exam, she does have mild tenderness to palpation in the right occipital groove, and her neck shows tightness in the paraspinal cervical area and the trapezius bilaterally. Neurological exam is otherwise normal. So, kind of a show of hands, what does everyone think here the primary diagnosis is? Anyone think it's cluster headache? About tension type headache and migraine? Chronic migraine? Or medication overuse? A little bit split here. What she actually has is chronic migraine. So before I talk about how we diagnose these different types of headaches, I wanted to share with you a study that was done by Stu Tepper and colleagues back in 2004, and they really wanted to evaluate how likely an episodic headache is a migraine. So this was a prospective open label study of about 1,200 people, and it was done in a primary care setting. So what they found was that when patients self-reported, or when a physician diagnosed migraine, it was about 99% correct. When patients were self-reporting or a physician was diagnosing non-migraine headache, they were about 98% wrong. And it was usually found out to be migraine later on in diagnosis. So what we take home from this is that migraine should be the default diagnosis for any recurrent and disruptive headache that's brought to the attention of a physician. So it's basically migraine until proven otherwise. So let's take a look at how we diagnose primary headache disorders. So we use the International Classification of Headache Disorders, and that's basically our manual for diagnosis of all types of headache. And this is set forth by the International Headache Society. Part 1 of the ICHD is the primary headache disorders. So that includes migraine headache, tension type headache, the trigeminal autonomic cephalalgias like cluster headache, and some other primary headache disorders. By far what we see is migraine clinically is the most common type of primary headache disorder. But when you look at epidemiological studies, tension type headache is the most common type of headache, and it occurs in about 30 to 80% of people. But that doesn't mean these people are actually coming to the clinic for their headaches. Most of us probably have had a tension type headache at some point in our lives, but it wasn't disabling or debilitating enough for us to even think about going to see our doctor about it. So what we often think about when we think about tension type headache is a band-like distribution or a vice-like grip around the head, frontally, occipitally, and more like a tight squeezing or pressure-like sensation. With migraine, we always think about it to be unilateral pain, throbbing in nature, associated with nausea and vomiting. But the reality of it is that migraine can look like both these types of headaches. And oftentimes what happens is migraine can lose some of its more severe features. And one important thing to note is that migraine does not have to be unilateral. And in about 50% of people, it's not. It can be bilateral, it can be in the exact same distribution as tension type headache, it can be occipital, it can be facial, it can be in the neck. So it can really be anywhere in the distribution of that trigeminal nerve system, which is all over our head and our neck. So let's take a look at how we diagnose migraine and tension type headache through the ICHD. So I'll discuss here episodic migraine, which by definition occurs less than 15 days out of the month. And it's a debilitating neurological disorder that lasts 4 to 72 hours. And it has to have two of the following features. So it should be either unilateral, pulsating, moderate to severe intensity, or aggravated by routine physical activity like walking up the stairs. And it has to either have nausea or light and sound sensitivity. So somebody who has a headache that's moderate or severe in intensity, that gets worse when they walk up the stairs, and they get nauseous with it, right there meets the diagnostic criteria for migraine. And then when we look at tension type headache, we think about tension type headache as a completely featureless headache. Think about it as exactly the opposite of migraine. So it can be bilateral, pressing, tightening sensation. It's mild though, that's the key takeaway here. Tension type headache is a mild intensity of headache, and it's not made worse by physical activity. Usually actually made a lot better if you try to go for a walk or do some cardio, it should get better. And there cannot be any nausea or vomiting associated with the headache. And if there's some light sensitivity, that's fine, but it can't also have sound sensitivity. So you can have one or the other, and usually they're very mild. So with a patient like Sarah, it can be very challenging to decide what her diagnosis is because she really seems to have features of both these types of headache. But that actually meets the diagnostic criteria for chronic migraine. So the headache in chronic migraine can look like either a tension type headache or a migraine headache. And by definition has to occur more than 15 days out of the month for more than 3 months' time. And certainly Sarah meets that diagnostic criteria. And by definition, you have to have about 8 days of the month that have these migrainous features of nausea, the light and sound sensitivity. But what I see in clinical practice is that does not always happen. What tends to happen are more days than not start looking like tension type headache. And this can happen for various reasons. Over time, chronic migraine can just look like that. But what happens about 50% of the time is that patients end up overusing their acute or abortive medications. And when that happens, their headaches tend to lose their features of migraine and end up looking more like tension type headache. So one of the most important things I will actually ask my patients is not how many headache days you have a month, but how many headache-free days? How many days of the month do you feel completely normal, like you've never had a headache before? And if they tell you, well, I never actually feel normal, there's always something there, there's always some sort of mild pain, they're very unlikely to have even episodic migraine or tension type headache. So I wanted now to take a look at the different phases of migraine. So there's actually 4 phases to migraine. Not everyone is going to have each one of these phases, but certainly you can have many of them. So we start with prodrome, which can last anywhere from hours to days before the onset of the headache even happens. And it occurs about 60% of people with symptoms such as neck stiffness, food cravings, fatigue, changes in your mood, yawning, urinary frequency. And only about 30% of people have aura. And this is another misconception here about migraine. Most people think that, well, to have migraine, you have to have aura. But it actually only occurs in 30% of people. And this can last anywhere from about 15 minutes to an hour, and typically occurs right before the onset of the headache. And when we talk about aura, the most common type of aura is actually called typical aura. 90% of typical aura is visual. So zigzag lines, tunnel vision, things like that may happen. But other types of typical aura are sensory changes. Somebody could have numbness or tingling on one side of the body, or changes in speech. And that can be anywhere from difficulty finding the right word to say, or difficulty reading or writing language, difficulty composing emails. So these are all actually typical forms of aura. And then we move on to the headache portion of the migraine. And this can last anywhere from 4 to 72 hours. And like we described before, is usually throbbing, pretty disabling, and associated with either nausea or light and sound sensitivity. After the headache, we go into what's called the postdrome, or now we're nearing the resolution of migraine. And this can happen for several hours to days as well, and can have similar features as the prodrome as well. So when you look at all of this together, one migraine attack can last several days, and in some people a week or longer. So really, the whole episode of migraine can be quite debilitating and disabling. So when we look at migraine disability, the Global Burden of Disease study in 2013 actually ranks migraine as the 6th leading cause of disability worldwide, with all headache disorders collectively as the 3rd highest cause of disability worldwide. Migraine is the 3rd most prevalent illness in the world and affects 12% of the population, and that distributes to about 18% of women and 6% of men. When we look at the prevalence of chronic migraine, most worldwide populations report about 1.4 to 2% of their population. And this is very similar to the United States as well. We see prevalence increasing throughout adolescence, peaking in midlife, declining after the age of 50, with the highest prevalence in women aged 18 to 49. And when we look at how chronic migraine comes about, so oftentimes what we see is episodic migraine will transform into chronic migraine. And this occurs in about 3% of people with episodic migraine. And there are several risk factors for this conversion, and some are modifiable and some are not. But if the more number of headaches you have at baseline, the higher the likelihood is that you'll transform into chronic migraine. And if you have a family history of chronic migraine, you have a higher risk as well. People who are obese, have sleep issues, psychiatric comorbidities such as anxiety or depression, either recent stressful life events like divorce, changes in job, moving, those can be risk factors as well. TMJ disorders, head trauma is a big risk factor. Probably the most important risk factor that we see is medication overuse. So when patients are overusing their acute or abortive medications, that has the biggest likelihood of transforming episodic to chronic migraine. So about half of the patients that we see in clinic that have a diagnosis of chronic migraine have medication overuse as well as a secondary diagnosis. And this occurs in about 1% of patients. And in my clinic population, this is more like 60 to 80% of patients. And our highest risk of causing medication overuse comes from barbiturate-containing substances like Fioricet and Fiorinol, and opioids. So these should never be used in the treatment of any type of headache, ever. And when we look at other medications that still will cause medication overuse but have lower risk, those include the triptans and NSAIDs. So with those types of medication, we have to limit their use to no more than 10 days a month. And that doesn't mean I can use 10 triptans a month and 10 NSAIDs a month. It means combined, all of my acute medications can't be more than 10 days a month. So the good news about chronic migraine is it's truly a fluid state. So it often reverts back to episodic migraine, and we see that in over a quarter of patients. But about 40% will remain transitioning in and out of chronic migraine throughout their lives, and about 33% will persist in chronic migraine. And there's some a few important points that will help patients revert back to episodic migraine. So if you actually stay on your treatment regimen, if you had a lower baseline headache frequency to begin with, if you don't have cutaneous allodynia, which is a sign of central sensitization, if you exercise, if you do some aerobic exercise every day, and if you're not overusing any types of medications. So one of the most important things is to really understand our barriers to treatment. So there were two large epidemiological studies that were done in the US, the AMPP and the CAMEO study, that really wanted to look at both the diagnosis and management of episodic and chronic migraine. So what they found was still less than 50% of people with migraine, so about 45% of those with episodic and 40% of those with chronic, actually consulted a healthcare professional about their diagnosis. Only about 40% of people with episodic migraine and only 10% of those with chronic migraine were actually diagnosed correctly. A quarter of people with episodic migraine got the right treatment options. Less than 5% of people with chronic migraine were actually prescribed appropriate treatment. So what we really see here is that the patients who are in the most need of treatment are not actually getting it. So I wanted to switch a little bit now and talk about some of the treatment options for migraine. So managing migraine is very multidimensional, and it involves not only medication options, but also non-pharmacological treatments as well. So I'll talk about the prescription medication options, including both acute and preventive treatment, some injection therapies, behavioral therapies, lifestyle modifications, and I want to end with some of the new therapeutic options, including the CGRP antibodies that have now been available over the last year to use in migraine prevention. So the most important thing I talk to my patients about before starting a medication is really our goals. So a good goal to have is to try to return to normal state within 2 hours and to be headache-free at 24 hours. But this isn't usually possible. You know, you might have, if somebody's starting with an 8 out of 10 pain, we might be able to reduce that to a 4 out of 10 pain. So maybe they're not disabled by it. Maybe they can still do some of their work or do some of the activities that they were planning on that day. One of the most important things I tell patients is to treat early in an attack. Medications work best the earlier they're treated and using an optimal dose. So despite that, most patients actually treat pretty late in an attack. They want to see, one, is this headache really going to turn into a migraine? And oftentimes they're worried about overusing or they're worried about side effects. And so if treatments are found to be ineffective, we really want to think about changing the medication, changing the formulation or the route of administration, and making sure we don't have any other interfering agents, considering adding on a different medication, an adjunct, or, you know, if nothing is helping, really thinking about the diagnosis there. And when we look at oral medications for acute treatment, these can be broken down to non-specific acute treatments and specific acute treatments. Most people that have come into the clinic have tried the over-the-counter NSAIDs, like ibuprofen and naproxen, but there are a couple other options out there. And then triptans really are the mainstay of therapy for migraine treatment. There are several options. So I'll discuss a little bit about how to choose the right one for your patients. And if triptans either aren't helpful for a patient or they don't like the side effect profile, there's always an option to use ergots like DHE nasal spray. The antiemetics I typically use as an adjunct therapy to either any of these, usually to help us keep our patients out of the ER or going to an urgent care. And in patients who can't tolerate the other forms of medication, I'll even use them alone. So when we look at the different types of NSAIDs, we know naproxen can be obtained over the counter. And then I typically use diclofenac, which comes in both an oral formulation and a powder that you can dissolve in water called Cambia. And the reason that one tends to work a little bit better is because it goes through the gut a little bit more quickly than a tablet would. I'll also use ketorolac. So ketorolac is also available in an IM formulation. So for patients who are having a severe migraine, nothing seems to break it, they can either come into our clinic and have an injection of ketorolac, or they can go to any urgent care and have that done as well. Oftentimes, I'll add an antiemetic to these options as well. So with antiemetics, you have to be careful because a lot of them can make your patients drowsy. So if patients say, I don't want to be sleepy throughout the day, I'll typically add on ondansetron. But for patients who want the added benefit of migraine improvement, the first three options will actually work better. So ondansetron won't really help with a migraine, but chlorchlorperazine, metoclopramide, and chlorpromazine and promethazine will. So I'll use them alone or an adjunct. So let's take a look at the triptans. Some important things. Always prescribe the full dose of a triptan. For instance, sumatriptan comes in 25, 50s, and 100 milligram tablets. I will never use anything less than 100 milligrams to start for a patient. It really just won't work. So I will prescribe 100 milligrams and I'll have them take sumatriptan right at the onset of their migraine. If they're still having a headache a couple hours later, they can repeat the dose. So your maximum dose is 200 milligrams in 24 hours. And our limit, of course, is 10 days a month in combination with all other medications. And so when we break down the different types of triptans, you want to think about which one's going to be best for your patient. Obviously, insurance companies try to make that decision for us, but when we have the option, I think about many different things. So sumatriptan not only comes in an oral tablet formulation, as do all the rest of the triptans, but it also comes in a nasal spray and it comes in a sub-Q injection form. So for patients who get a lot of nausea, for those who vomit, or for those who have an acute onset of headache that's to its severe maximum intensity, I'll use other formulations like the nasal spray and the injectable. Zolmitriptan also comes in a nasal spray as well, and zolmitriptan and rizatriptan come in oral disintegrating tablets. So again, for those who get pretty nauseous, those are really good options. And most of the triptans have a pretty fast onset. Within a couple of hours, they peak after a few hours. But there are a couple options for those who have longer duration headaches and that are slower to their peak onset. So we have their naratriptan, which has about a 6-hour half-life, and frovatriptan that actually has a 26-hour half-life. So those are good options for longer duration headaches. So triptans are typically underutilized and underprescribed because of a few myths that have come about over the last couple of decades. So in 2006, the FDA put out a preliminary alert warning about the potential threatening risk of serotonin syndrome when triptans were combined with SSRIs or SNRIs. And this was actually based on 29 anecdotal case reports. These case reports were then further analyzed by a group of headache specialists. When they actually broke things down, most of these patients didn't actually meet any criteria for serotonin syndrome. And then when we looked at other studies, so a prospective safety study on sub-Q sumatriptan, so actually probably the strongest triptan, with about 1,800 patients who are on SSRIs, found no reports of serotonin syndrome. And what's also important to note is that triptans are 5-HT1B and 1D agonists, whereas serotonin syndrome is thought to be caused by activation of the 5-HT2A receptor. So really, there's not really a risk for serotonin syndrome with triptans and SSRIs. So in 2010, the American Headache Society put out a position paper stating there's inadequate data to suggest limiting the use of triptans in addition to SSRIs or in monotherapy when considering serotonin syndrome risk. So certainly you can use triptans in patients who have or are on SSRIs. And then triptans and cardiovascular disease has always been quite controversial as well. So this again was based on case reports that in suggesting an association between triptans, stroke, MIs, and ischemic heart disease. A 2004 study looked at over 13,000 patients prescribed triptans and actually found no association between triptan prescription, stroke, MI, or ischemic heart disease, or mortality. And later on, a 2014 meta-analysis that looked at several studies found no significant increase in cardiovascular events with triptans, and this was based off 3 studies. What they did find is there may be an increased risk of stroke, and in those who recently had a stroke and recently used a triptan, but another study did not show that risk. So in my patients who've recently had a stroke, I certainly am not going to use a triptan. Patients who've recently had an MI or have uncontrolled hypertension, I'm not going to use a triptan. But those with a history of it, I think it's quite safe to use a triptan. So just some takeaway points about acute treatment. Always use the full dose when prescribing a medication. Do not ever prescribe opioids or butalbital-containing substances. And the most important point here is to really limit all acute medications to 10 days a month to try to avoid medication overuse or rebound headache. And to encourage my patients to do this, I have all of them keep a headache diary. This is the most important way for us to be able to see if they're improving and for us to know what medications they're taking and if they're at risk for medication overuse headache. So we know that most patients are going to benefit from an abortive or an acute medication. It's important now to decide when we're going to use a migraine preventive treatment option. For, I would say, most of my patients, they will need a preventive treatment option. But there's some important ways to kind of identify these patients. So if patients are having more than a few migraine days a month, it's important to consider a treatment option. Or if their migraines are quite disabling, even if they have one migraine a month, but it's really disabling, it's lasting a week, they're unable to go to work, then it's important to consider a preventive option. And most importantly, if your patient wants to be on a preventive treatment, this certainly should be an option. And in those who are at risk of developing medication overuse, and now you're going to know because they're going to have a headache diary, you certainly should start a preventive treatment option. So I really talk about goals of headache reduction with my patients before starting treatment. Most patients are going to come in and think, well, I'm going to start this medication and I'm going to have no headaches starting tomorrow. And although we would love that, that will 100% of the time not happen. So a good goal is to think about 50% reduction in migraine severity or frequency. So that's a good first goal to have. And in patients with chronic migraine, I would say we want to lower that goal dose or that goal to about 30%. Because for the longer you've had migraine and the more severe it is, probably the more difficult it's going to be to reduce that headache severity and frequency. And with all preventive treatment options, we want to start a very low dose and increase slowly. So I get my patients to their goal dose over 1 to 3 months because I want to avoid any types of side effects. Triptans the preventive options do take a long time to be effective. So this can be months. So I usually will see a patient, I'll prescribe a medication, and then I'll have them come back in 3 to 4 months. And at that time, if things are going well, I can keep them on that dose. If it's not, I can increase if there's no side effects, or I would add on another therapy to that. I always want to consider comorbidities when actually choosing a preventive treatment option. And then, like I just mentioned, combining preventive treatment options. So when we look at what's actually FDA approved for migraine prevention in terms of our oral treatments. So there are actually no oral medications that are approved for chronic migraine. There are 4 that are approved for episodic migraine: topiramate, Depakote, propranolol, and timolol. I don't know anyone that's actually ever used timolol in prevention. And Depakote, because of its not so favorable side effect profile, I actually have never used also. So topiramate and propranolol I use very frequently, but this just goes to show you most things we use are actually off-label. But for chronic migraine, we certainly use the same oral preventive treatment options. But other options I'll talk about later are OnabotulinumtoxinA, which is only approved for the preventive treatment option of chronic migraine, and the CGRP antibodies that are approved for both episodic and chronic prevention. So the American Academy of Neurology, as well as the American Headache Society, has established ratings for level of evidence to help us decide on various treatment options. So level A means there's been multiple randomized clinical trials or meta-analyses. B means data is derived from single randomized clinical trials or some large non-randomized studies. C suggests it's a consensus opinion from experts or some retrospective studies or registries. U really means there's conflicting or inadequate evidence. So when we look at all these treatment options, most of them fare pretty well. So when we think about our patient Sarah, we know she has a history of kidney stones. So given the fact that topiramate can cause kidney stones, that certainly isn't a good option for her. She does have insomnia, and she's actually underweight. So for her, I actually prescribed a tricyclic antidepressant. Oftentimes people use amitriptyline. I tend to use nortriptyline just because it has a little bit better side effect profile. So I started her on nortriptyline, had her come back after a few months. And so she was about 25 to 28 headache days a month. And she went down to about 20. So she went down a little bit, had some benefit, but probably not enough. And she was still overusing her triptans and her NSAIDs. I actually ended up adding propranolol to that. She couldn't tolerate propranolol. Her blood pressure and heart rate did not tolerate that, so we stopped that medication. And in her, she has a diagnosis of chronic migraine. The next best treatment option would be onabotulinumtoxin, or Onabot, for chronic migraine. So that's what I did for her. And so there's quite a bit of evidence to suggest some pretty large studies show that Onabot is helpful in reducing migraine severity and frequency. So 2 large studies looked at Onabot for prophylaxis of chronic migraine in over 1,300 patients. Their baseline headache frequency averaged about 20 days a month. Pooled analysis of both these studies showed a significant decrease in those that were on Onabot versus those who were receiving placebo. And then what they did in a subset of patients is took this out even further. So instead of just doing 3 cycles, so that's once every 12 weeks, they actually looked at 5 cycles. So over a year of Onabot treatment versus placebo, 2 cycles, and then 3 cycles of Onabot. And what they found is that those who got 5 cycles did even better than those who had 3. So the longer you stay on Onabot, the better your outcomes are. So with my patients, oftentimes I'll have patients who come in and say, well, I tried Botox once and it didn't work. So I have them try it at least 4 times. So you're trying onabotulinumtoxin for at least a year or greater. So you're doing it every 12 weeks. I would say give it at least a full year trial before calling Onabot a medication failure. So let's take a look at the PREEMPT Protocol for chronic migraine. So this is a standardized protocol that we use for migraine prevention. So it includes injections in 7 different muscle groups, and it's 31 sites. So across your corrugators, your procerus, your frontalis, temporalis, occipitalis, paraspinals, and the trapezius. So the common side effects that we do see are eyelid drooping and neck pain. So when you look at this picture here, the frontalis is actually, they show you injecting it a bit low. So with my patients, usually for the frontalis, I inject sometimes a little bit closer to the hairline if they're at risk for a droop, but certainly higher up. The frontalis is a really big muscle in your forehead, so you don't have to inject it low. And then the neck pain as well. So looking at this picture here, the occipitalis injections look like they're very close to the cervical paraspinals. The occipitalis should actually be a bit higher than what you see here. And for the paraspinals, always look at the patient's hairline and make sure you're above the hairline when you inject. So typically, in addition to Botox, I'll add other injectable treatment options such as nerve blocks. And when I do Botox and nerve blocks, you have to make sure that you're not injecting on the same day. They have to be at least 2 weeks apart. We don't want people getting lots of injections all at once. So peripheral nerve blocks are really used in conjunction, and common sites are shown here, which are the greater occipital nerve and the lesser occipital nerve, both branches of the cervical roots, and the auriculotemporal nerve, the supraorbital, and the supratrochlear nerve, which are branches of the trigeminal nerve. So we can use various types of anesthetic for nerve blocks. Usually it's bupivacaine or lidocaine. We use 0.75% bupivacaine in our clinic. Steroid is actually never used in migraine treatment. Steroid is really only reserved for those who have cluster headache. And in terms of injection frequency, this can actually be quite varied, from weekly, monthly to as needed. There was a study that came out a few years ago that actually looked at occipital nerve blocks for refractory chronic migraine prevention. So what they did was they injected patients weekly for a month and then monthly thereafter, and found that that injection frequency helped reduce migraine severity and frequency. So that's typically what I do for nerve blocks. And with nerve blocks, I'll usually combine those with trigger point injections. So I won't just do like a greater occipital nerve block. I'll actually do trigger points, and these are the most common sites that I use. So can inject into the neck, and usually I'm injecting the trapezius and the muscles around the trapezius. And again, I'll do these weekly for a month and then monthly thereafter. And these are okay to combine with nerve blocks because you're using the same injectable. So here I'm again using bupivacaine. So let's take a look at some of the non-pharmacological treatment options for migraine. So whether or not my patients want to be on prescription meds, I will always recommend, number one, lifestyle modifications. So routine and regularity are the most important preventives for migraine in general. So when it comes to sleep, I actually make my patients pick a sleep time and a wake up time and stick to this every day, regardless of if it's a weekend or a weekday. And I recommend aerobic exercise 20 to 30 minutes a day, every single day. And this has to be moderate intensity where you're getting your heart rate up and you're sweating. And I always will recommend not skipping meals, because whether you feel like it's a trigger or not, when your brain is off of a routine schedule of meals, that can be a significant trigger for migraine. There are also many natural supplements or nutraceuticals that have been shown to be effective for prevention of migraine. Magnesium, riboflavin, and coenzyme Q10. We don't typically use feverfew anymore, but I will certainly give these as options to my patients who even want to start with a more natural way before trying a prescription medication. And behavioral treatments, many of them actually have grade A evidence in migraine prevention, including relaxation training, biofeedback, and cognitive behavioral therapy. So most of my patients who come in, especially those who come in with chronic migraine, I actually refer them to our pain psychologists. And our pain psychologists can help them, can tailor with them other behavioral treatment options, especially biofeedback, because they oftentimes will do biofeedback. And they have many courses, different classes, and online tools for relaxation and even for CBT. So now let's take a look at some of the new therapeutics and the CGRP monoclonal antibodies for prevention of migraine. So a little bit about CGRP. It's a 37 amino acid neuropeptide, and it's a potent vasodilator. So it was found to be elevated in acute headache attacks, and triptans were able to normalize these levels. In those with chronic migraine, it was found to be chronically elevated, and studies showed that administering CGRP to a migraine sufferer triggered an attack that was phenotypically similar to their migraines. So the monoclonal antibodies have been clinically designed for both the preventive and chronic migraine. So they act either on the receptor, so blocking the CGRP receptor, or blocking the CGRP molecule, the ligand itself. So there's one out now that blocks the receptor. There's two on the market now that block the ligand itself. So this is a very busy slide, but this is just really looking at the phase 3 trials in episodic migraine prophylaxis. So the three that are on the market now, you may have heard of Aimovig, which is arenimab. There's galcanezumab or Emgality, and fremonizumab or Ajovy. So Aimovig, the first one that came to market about 1 year ago, is an antibody to the receptor itself. The other two are antibodies to the ligand. There is another one that's going to be coming on the market, I would say fairly soon, maybe by the end of the year, which is a little bit different in terms of its route of administration. So the three that are on the market now are actually subcutaneous injections, usually once a month, this at home. The new one that's coming up called eptinizumab will actually be a quarterly IV infusion, so a little bit different. But when we look at the data here for prevention, they all pretty much looked at the same primary endpoints. So we're looking at the reduction in number of migraine days a month, and they all had pretty similar secondary endpoints. And there we're looking at responder rates. How many improved in terms of 50%, 75%, and some even did 100% responder rates. And what we find is they all did fairly well and fairly similar to each other. So we're looking at, let's say, someone starting with 9 migraine days a month. We're looking about a reduction in half of those migraine days a month, with about 60% of people having a 50% responder rate or more. Both galcanezumab and eptinizumab showing 75% responder rates of 20 and 30%, and galcanezumab actually having an 11%, 100% response rate. So someone going from having 10 migraine days a month to 0 that next month. So when we look at the CGRP antibodies in chronic migraine prophylaxis, we have very good results as well, but they're never going to be as good as in episodic migraine because these patients have been suffering for a lot longer, and they're going to take a lot longer to improve. So we still do have some important reduction here in migraine days. Our baseline patients were having almost 20 migraine days, and we are seeing 50% reductions in about 40 to 60% of patients with any number of, with actually all of the CGRP antibodies. So just some important take-home points, because patients are going to come to you probably asking very specifically for one of these. So let's take a look at these. So the three that are on the market, Aimovig, Emgality, and Ajovy. So both Aimovig and Emgality are auto-injectors. So it's a pretty easy pen, pre-filled pen that a patient can use. Ajovy right now is a pre-filled syringe. So for patients who are needle phobic, probably not the best idea. And again, Aimovig is a receptor antibody, whereas Emgality and Ajovy are ligand antibodies. So the other important thing to note are some of the side effect profiles. What's really great about our CGRP antibodies, it's just a month dosing, and their side effect profile looks pretty fantastic. Site irritation was really the only thing seen in clinical studies, but with Aimovig, we are seeing constipation. With a lot of our patients, they do have comorbid constipation. So if somebody does come to me saying, I have that, I wouldn't give them the option of Aimovig. I would think about the other two. They're all offering now free trials. So it's pretty great for our patients that they can get a year free of medication. And most insurance companies have now picked up either one or two of them on their formulary. So a couple things to conclude with. A headache that warrants a physician evaluation is migraine. Episodic and chronic migraine are both underdiagnosed and undertreated. So we have to really think about combinations of acute and preventive treatments to treat migraine. We want to make sure we're limiting our acute medications to no more than 10 days a month to avoid medication overuse headache. And the new therapeutic targets such as CGRP antibodies are available for episodic and chronic migraine. Prevention in Sarah, I actually started her on Emgality, and she went from 20 migraine days a month to 10 and is no longer in medication overuse headache. So thank you, and I'm happy to take any questions.
Thank you for a detailed discussion of a very chronic and unfun to treat problem. Curious, of course, again, about the predominance of women.
Mm-hmm.
So do we know anything more about pathogenesis? Because my understanding in the past was vasoconstriction accounts for the aura, then it's followed by excessive vasodilatation, and maybe that's why some of the approaches that are used, air blockade, et cetera. So do we know anything more about that?
Yes, actually.
The other is, have we seen or heard about such degrees of migraine in other simpler populations, natives in South America, Africa? In other words, how much of modern life is contributing to this response in the susceptible host? And then finally, what is the cost of all of this? Because is Sarah back to work?
So first, prevalence is actually very similar worldwide. When we look at the prevalence of migraine, it's in all countries, it's really about 18% of women, 6% of men. So we're looking at either anywhere between 10 to 15% worldwide. Chronic migraine ranges anywhere from 0.4 to 5%, depending on the country and analysis done. In terms of pathophysiology, migraine is actually a neuronal disorder. So it's not thought to be vascular at all, as was previously thought. So it's a disorder of hyperexcitability. The vasoconstriction and vasodilation are actually epiphenomenon when you look at the pathophysiology of migraine. And then in terms of cost to society, it's billions, right? Because of lost productivity days. And then when we look at the cost of treatment, most oral medications are actually generic. So those are very cheap. Our CGRP antibodies, the newest stuff, and Botox is covered by insurance. So for most patients, that's free. The CGRP antibodies are about, each is out-of-pocket cost is only $7,000 a year. But again, covered by most insurance companies.
Thank you for a great talk, and fascinating talk in a way too, because I think it speaks to a lot of our core challenges in medicine. Issues around gender and how we manage gender in treating patients, issues around how we conceptualize pain. But one question I did have was in terms of other serious headaches like cluster, trigeminal neuralgia. Are there any risks associated with missing those diagnoses and treating a patient as if they have migraine?
Yeah, that's a great question. So patients with like cluster headache are often misdiagnosed for many, many years, 5 to 20 years. And cluster headache is actually the most intense, severe type of headache pain known to mankind. It's known as suicide headache because patients do end up committing suicide who have cluster headache. So it's really important if after several months you're not finding that your patient is getting better, or you're just not sure, sending them and referring them to a headache specialist who can better diagnose something like cluster headache.
Curiosity question.
Yes.
What is or is there an association between atrial septal defect and migraines?
No, there is not.
That's debunked.
Yes.
We're debunking lots of things.
Yeah, I know, right?
Not military.
I know.
Does pregnancy change migraine?
Yes, it does. In 2/3 of women during pregnancy, because estrogen goes up during pregnancy and stays elevated. So after about the first trimester, those who have migraine, 2/3 of them actually get a lot better and feel better. So pregnancy can be used as a treatment option. But in about 1/3 of them, it can actually stay the same. If your patients are getting worse during pregnancy, especially towards their 2nd and 3rd trimester, though, we really want to think about secondary causes of headache. So that's when it warrants imaging studies.
So thank you for a great talk. So somewhat along that same line, can you make a comment about women in oral contraceptives when they have migraines?
Yes, that's yeah. Here's another myth that's going to be debunked now. So it was originally thought that women who have migraine with aura cannot be on estrogen-containing birth control. So that was originally studies done several decades ago. We're looking at oral contraceptive pills that had greater than 50 micrograms of estrogen. We never use those anymore. Even our high-dose estrogen-containing substances now don't even go anywhere near 50 micrograms. And even then, it was still kind of iffy. So estrogen-containing substances are actually definitely okay to use in anyone who has migraine, whether they have aura or not. And certain estrogen-containing birth controls can actually help prevent those who have menstrual migraine or menstrually related migraine. And in those types of oral contraceptive pills, we want to make sure that drop in estrogen from your placebo to your active week is less than 20 micrograms. Then that can actually be used as a preventive.
Thank you so much. That was a really interesting talk. Can you comment a little bit on people who are postpartum who have migraines and what the best treatment options are?
Yeah, so treatment actually is a little bit different during pregnancy and postpartum. And that will depend on if your patient's breastfeeding or not. So once you're out of pregnancy, you can use most of the same oral preventives as prior to pregnancy. During pregnancy, during breastfeeding, actually, you can go back to using triptans. Elatriptan actually is the least excreted in breast milk, so that's a very good option for those who are getting migraines postpartum. And then postpartum, certainly if there's depression, comorbid depression, really think about using an SSRI or a TCA or something that can help both. But you're fairly safe to start using other treatment options. What's very safe and the most safe during pregnancy and right after are nerve blocks. So they have no harm to you or and it's not going to be excreted in breast milk. So that's a great option. I will certainly still use Botox for those patients as well.
Thank you very much. Oh, sorry. Go ahead.
Thank you for this wonderful talk. And just you mentioned multiple times about the connection between the trigeminal nerve and migraines. If you could just elaborate a little bit further on that.
Yeah, so the pathophysiology of migraine stems from the trigeminal nerve system. So that has a lot of moving parts and components. So the trigeminal nucleus caudalis, then you have your cervical nerves, you have your cortex, and so the trigeminal nerve system is everywhere. So it's what goes to your dura, to your face, to your neck, everywhere. So, and these all will converge on the trigeminal nerve complex. So all of these parts, so the cortex is thought to be activated, and then these all kind of converge on the brainstem, which is thought to be maybe where the migraine generator is. So it's really a neuronal disease when you look at everything. And then as an epiphenomenon, things like vasodilatation occur. So I know that would be a whole nother talk. I'm happy to do that sometime, but migraine pathophysiology is pretty complicated because we don't know everything yet, but we do know the trigeminal nerve is the biggest component.
Thank you.
Thank you very much.